I'm Dr. Glenn Bauman. I'm a professor in the Department of Oncology at Western University in London, Ontario, and I'm happy to deliver this introductory lecture on the use of PSMA PET for prostate cancer radiotherapy. So our learning objectives here are really going to have a very high-level overview of the role of PSMA PET CT in radiation management of prostate cancer. We'll try and highlight some of the important trials and some case examples utilizing PSMA PET CT to guide radiation therapy. And we'll have a very quick introduction to the concept of theragnostics for prostate cancer. Just as a big picture regarding prostate cancer, this is the most common cancer among men, and about 1 in 7 men will get prostate cancer over their lifetime. Fortunately, only about 1 in 28 will succumb to this cancer, so there are a lot of men presenting with curable disease. As we can see, it's a disease that occurs within the prostate gland, which is situated just below the bladder, in front of the rectum and the pelvic floor. And as we saw before, the incidence of this cancer much higher than the mortality rate of this cancer. In terms of our management of prostate cancer, it all starts with early detection, and our tools for early detection are actually fairly limited. We have screening tools based on digital rectal examination and PSA blood tests, and when prostate cancer is found, it's typically on the basis of an elevated PSA and then subsequent biopsy, which confirms the presence of prostate cancer in the gland. And then in terms of our management from there, it really depends on the extent of the cancer. And you can see from this diagram, as the PSA level at the time of diagnosis goes up, the probability that the cancer is spread beyond the prostate to either sites within the pelvis or elsewhere in the body also goes up. And as a consequence, our available treatments tend to change as the extent of the cancer changes. So in the very early stages of prostate cancer, we might observe cancers without active treatment. We might offer men surgery where cancers are localized to the prostate only and can be safely resected. Radiation treatments can have a role across the spectrum of disease, but the target will vary depending on the extent of the cancer. And then as the cancer gets more advanced, the role of systemic therapies increases because the treatments need to address the burden of cancer throughout the body. Imaging has played an important role in the management of men with prostate cancer, and to date, imaging has been most useful in the detection of prostate cancer in the prostate, and we have very useful tools for being able to target the prostate and guide biopsies into the prostate, or detect cancer within the prostate, or to guide radiation therapy to the prostate. So on the left here we have examples of prostate ultrasound, MRI, and radiation acquired CT scans to guide radiation treatments. But we are more limited in our ability to understand the extent of the cancer outside the prostate because of the limited sensitivity and specificity of our conventional imaging, being primarily CT scan and bone scan. And for example, in the middle panel you can see a sagittal view of a CT scan, and it is hard to discern on that CT scan. There's actually spread of the cancer from the prostate to lymph nodes in the abdomen. And then the bone scan on the right is showing sites of spread of cancer to the bone, but this is not the most sensitive for picking up early spread of cancer to the bones. What has really changed the management of prostate cancer in the last decade or so has been the introduction of molecular imaging for prostate cancer. So molecular imaging uses positron emission tomography to utilize tracers which are designed to attach to prostate-specific proteins or address prostate-specific metabolic processes. And the tracer that's proven to be most useful is tracers that are targeting a surface protein called PSMA, and this can be targeted through small molecules or antibodies. Most PSMA PET tracers now are small molecules labeled with a positron emitting isotope such as gallium or 18-fluorine. And there's a number of tracers available which all perform relatively well. And so you can see now in this same sagittal view that we saw before, we now have a very good picture of where the prostate cancer is, both within the prostate, so at the bottom of the image, below the bladder, which has the tracer in it as well, but you can see the prostate lighting up with the tracer. And then in the middle of the CT, you can see the tracer accumulating within regional lymph nodes. And then up higher, that's normal physiological uptake in the liver. On the right image, this is another type of hybrid image where we have a hybrid PSMA PET MRI. And in this case, you can see the anatomy, cross-sectional anatomy of the prostate very well with the peripheral zone well visualized, and the PSMA PET tracer lighting up a focus of prostate cancer in the right peripheral zone very, very well, and able to localize the cancer much more easily than with MRI alone. So the role of PSMA PET imaging has proven to be very much influencing our ability to detect and delineate extent of prostate cancer in the prostate itself, but also stage men properly and understand the extent of disease outside the prostate if it is present. So the role of molecular imaging or theranostics in prostate cancer really spans the spectrum of disease, and this is just another way of visualizing the journey of a man with prostate cancer, and this would be a man where there was ultimate relapse. But at the beginning of the journey, you have local therapies such as prostatectomy or radiation therapy with subsequent response, but then later recurrence, typically in this case showing up outside the prostate area, treated with hormonal therapy, again with a valley in the tumor activity, but eventual development of resistance to hormonal therapy, and then subsequent therapies such as chemotherapy being deployed. And this is accompanied by a change in the trajectory of the man, becoming relatively, or a man who may be relatively asymptomatic in the early stages of the disease when the cancer is not metastatic, to becoming more symptomatic, and the biology of the cancer going from androgen dependent or sensitive to androgen independent. And again, in our early days, we in the diagnosis, we would be relying primarily ultrasound and MRI, and then conventional imaging, CT and bone scan later in the course of the disease. But where we see now is that PSMA PET and this idea of theranostics, which are targeting these specific cell targets, can really play a role across the spectrum from diagnosis in terms of staging and guidance of therapy to the actual later stages of the disease, where we can use these tools to measure response, but also to actually deliver therapy. So the availability of PSMA PET has been really become very prevalent over the last 10 to 15 years. Early tracers introduced included tracers like choline and FRCPC, and then later PSMA PET or PSMA PET tracers. And there's been a large body of evidence accumulated to help us understand the performance of these tracers. So this was a large meta-analysis, and it looked at the ability of PSMA PET to delineate or detect cancer in the prostate itself. And you can see in the left panel that sensitivity, specificity, positive predictive value, negative predictive value, all quite high. in the 80% range. And then on the right, showing the ability of the PSMA PET at diagnosis to detect spread of the prostate cancer outside the prostate to regional lymph nodes, with that performance being somewhat higher in higher risk men where you would expect a higher incidence of involvement of lymph nodes, and maybe a bit less so in intermediate risk men. But overall performance again is quite high in terms of those metrics of sensitivity, etc. There are, in addition to the retrospective data looking at collective experience with these PET tracers, there are prospective studies and randomized trials which are starting to read out to, again, help us understand the utility of PSMA PET compared to our traditional approaches with conventional imaging like CT and bone scan. This is a very influential trial, Pro-PSMA trial, which was a randomized trial. So these were high-risk men, so higher PSA, higher Gleason score, higher T-stage, and they were randomized to initial staging either with conventional imaging with CT or bone scan, or imaging with PSMA PET. And then there was a crossover. So men imaged with conventional imaging could be imaged with PSMA PET and vice versa. And what they found was that as a first imaging modality, the performance of PSMA PET CT was superior compared to conventional imaging across all the different parameters and potential disease sites. So in terms of delineating local regional disease in the pelvis or distant metastasis. And the other important thing they noticed was that men who had conventional imaging first and then had PSMA PET afterwards, there were a substantial number of men where PSMA PET picked up lesions that were not detected on conventional imaging, whereas the opposite was not true. So men who had PSMA PET first, the number of lesions picked up on conventional imaging compared to the PSMA PET was very low. So this would argue for PSMA PET CT as being the primary and only staging modality for these high-risk men. And this is, again, just looking at our case example, sagittal view of the plain CT in the middle, PSMA PET on the left, showing the highlighting the periodic lymph nodes involved, and then in the far right panel, an example of a radiation plan which was developed for this man, which now treats not only the prostate, but the regional lymph nodes, including giving additional dose to the lymph nodes in the periodic region. So we're now able to use the staging information to help adapt our radiation plans, either by modifying the volume or the dose of radiation delivered according to the extent of cancer we see on these scans. So this is the premise behind an important study that's being done in Canada called PATRON. And this study is important because it's asking a pure imaging question with PSMA PET. So this is looking at high-risk men with prostate cancer, either in the primary setting, so those are men who with high-risk features who have not yet been treated, but also men being treated in the post-radical prostatectomy salvage setting. But just thinking about the primary high-risk men, like we just saw with the Pro-PSMA study, what this study is now doing is it's for those men who are enrolled in the study, the initial treatment plan is developed on based on conventional imaging. So men enrolling on PATRON are randomized to either PSMA PET or the plan based on conventional imaging. So there's an initial conventional imaging based plan that's developed in advance of that randomization, and then men who are randomized to PSMA PET have the PSMA PET CT scan done, and then radiation treatments are tailored to the findings on that PET scan. So that may include modification of the volume of radiation to include sites of disease that were not in the original plan, or dose escalation with higher doses of radiation to sites of cancer identified with the PSMA PET. Whereas those men randomized to the conventional imaging-based plan will have the original plan executed without any modification because there is no input from the PSMA PET imaging. And the outcome of this study is failure-free survival. So this is a clinical endpoint, not just a notional endpoint like detection rate or change in management. These are actually outcomes linked to patient, longer-term patient outcomes. And this study will be very important in helping us to understand the importance and the efficacy of including PSMA PET as an integrated part of radiation treatment planning for this group of men. So this is just giving an example of some of the PSMA-based intensification that happens on Patron. So if there are no new lesions detected, then there's no change. Patient gets their conventional imaging-based plan. If there were new local regional sites of disease identified, then those men receiving radiation would have their radiation plan adjusted to make sure all sites of disease were being treated. So, for example, if you're treating just prostate alone and you saw uptake within lymph nodes, then you would change your radiation plan to include the regional lymph nodes, and then you could also escalate dose to sites of cancer within the prostate identified on PET, or give extra dose to involve lymph nodes on PET scan. Interestingly, in Patron, there was provision for men who are undergoing surgery to have PSMA PET modification and integration of radiation with that surgical planning. That was a relative minority of men on that study. Most of these men are receiving primary radiation or salvage radiation. The adaptation extended to those men who had extrapelvic disease. So if there were men who had 1 to 5 sites of disease outside the pelvis, they would still proceed with their conventional imaging-based plan, which would be pelvic radiotherapy, and then SBRT added to treat the PET-identified sites of disease outside the pelvis. And then the change in response to widely metastatic disease really was a switch to hormonal therapy or androgen deprivation therapy, with the provision that radiation to the prostate could be included if the prostate was still intact. So a range of actions that could be implemented depending on the findings on the PET-CT. We do not have outcomes from this study yet. That's still a little bit down the road from the time of this presentation. But what we did find was that in men randomized to PSMA PET-CT, almost half of men had lesions detected on the imaging, and among of those men who had lesions detected, there was some form of intensification in terms of adjusting the dose or the volume or both. So it seems like the PSMA PET is changing management in a significant proportion of men on the study, as we would expect, and we look forward to seeing the longer-term outcomes to see if that translates into improved failure-free survival. And here's an example of a man treated with a Patron-style treatment, so high risk based on a higher PSA of 34, and on PSMA PET was shown to have disease in the prostate and in a left external iliac lymph node. So as part of the treatment on Patron, they had dose escalation to the lesion in the prostate to 66 gray and 20 fractions, with the entire prostate receiving a standard dose of 60 gray and 20 fractions. The elective lymph nodes receiving 44 gray and 20 fractions, and the involved node again being boosted to 66 gray and 20 fractions. So this was achieved while maintaining all of our usual organ at risk constraints. So we're not overdosing bowel or bladder or rectum with these boost doses. And again, the trial will help us to understand whether this dose escalation based on PSMA PET is going to translate into improved outcomes. This is another example of a patient treated on a different study. This one was called the ARGO study, and in this case we're using a radiation technique called stereotactic radiotherapy to deliver the radiation over an intense, highly compressed schedule. So in this case, giving the prostate doses of 35 to 40 gray over 5 treatments, given every other day over 2 weeks. And in this study, we are using a PSMA PET to help us identify sites of cancer in the prostate, which can then be, again, dose escalated. In this case, up to as high as 50 gray and 5 fractions, with the whole prostate receiving 35 gray and 5 fractions. In this case, in this study, we're using hybrid PET MRI. So MRI supplying the cross-sectional anatomic imaging for localizing the PET signal changes as compared to the hybrid PET-CT studies that we've seen in the previous slides. So here on the left panel, we can see upper left, MRI, cross-sectional image, mid-gland, and towards the midline there's a darker section of the peripheral zone, which is suspicious for prostate cancer. When you overlay the PET signal, this lights up very intensely, confirms that this indeed is a focus of prostate cancer. And then on the far right, one can see the adapted radiation plan, where the whole prostate is being treated to 35 gray, and then the PET-identified focus of cancer is escalated, in this case, to 44 gray in 5 fractions. The dose-limiting structures of the urethra and the rectum precluded going to the full 50 gray. In the bottom panel, you can see a 6-month PSMA PET MRI acquired after treatment, and in the lower right panel, you can see that intense uptake in the prostate has gone away, and you have just some uniform background activity in the prostate, showing a complete PSMA response to this treatment. And so this is again a prospective study being done to characterize the safety and the efficacy as measured by serial PSMA PET imaging and PSAs after treatment for men with high, intermediate, or high-risk prostate cancer. So when we talk about the role of PSMA PET in men at the next stage of disease, which would be men who are recurring after primary treatment, there are a number of scenarios where PSMA PET can be helpful in terms of understanding the extent of disease and understanding where radiation might play a role in helping manage that recurrence. So here we're talking about identifying local, regional, or metastatic recurrence after primary prostatectomy, primary radiation, or combined prostatectomy and radiation. And this can happen in the setting of hormone-sensitive prostate cancer, where you may have a rising PSA, and at low PSA levels, conventional imaging is uninformative, will not show you where the recurrence is. Could also happen in the setting of castrate-resistant prostate cancers, men who have been placed on hormone therapy in response to prior recurrence, who now have rising PSA again, and again at lower PSA levels, conventional imaging may be uninformative. And there may be a role in men with progression in the castrate-resistant setting, where conventional imaging may be positive, but it may be hard to understand in that setting, is there a subset of lesions that is progressing, or are all lesions progressing? And if so, could radiation play a role in dealing with a limited number of sites where there may be progression if the overall status of the cancer is controlled with a systemic therapy? So in Ontario, we have introduced PSMA PET imaging in the context of a registry study. This was opened in 2018. At that time, there were no Health Canada approved PET tracers available, so we needed to make these PET tracers available in the context of a prospective registry study. And this report was on the first 1,300 men imaged as part of the registry study. For the most part, these men were those men who had failed after primary radical prostatectomy, though there were smaller groups of men who failed after radiotherapy, who had progressed on salvage hormonal therapy after prostatectomy. What we found is in our jurisdiction, we replicated what was seen in other jurisdictions. We saw that the overall detection rate of identifying sites of disease was fairly high at about 2/3 of men. And then interestingly, among those men who were identified as having disease, the majority of men had limited recurrences, either within the pelvis or limited metastatic recurrences, where you could potentially intervene with something other than salvage systemic therapy. So about half of men had actionable disease in the sense that you could use some sort of lesion-directed therapy, either surgery less commonly, or stereotactic radiotherapy or regional radiotherapy more commonly. And we found that the incidence of a positive PET scan was highest in those men who had developing castrate-resistant disease, which we might not be surprised about, that men who had known oligometastatic disease and were being re-imaged at the time of further recurrence had high rates of positivity. Men who had prior radiotherapy had high rates of positivity, largely because of the ability to detect persistent cancer in the prostate. And then those men who had salvage radiotherapy having higher rates of disease for PSA rising after prostatectomy. These are all relative odds ratios, with the baseline being those men with prostatectomy only who have biochemical failure. And then the other interesting finding was that as the PSA level went up at the time of PSMA PET imaging, the detection rate increased. So the higher the PSA, the higher the likelihood of finding disease, with plateau over PSAs of 1.0. So again, in a post-prostatectomy setting, a PSA of 1 is relatively high. PSAs in more of the actionable range, 0.2 to 0.5. Detection rate was a bit lower, but still useful, and we saw probably a third to a half of men where PSMA PET could detect disease even at those low PSA levels. An interesting analysis that was done in the high-risk M0 space, and this is where a lot of drugs had been developed. The androgen receptor pathway inhibitors, such as the ARATs, really were designed to address this space in their early drug development, and so this idea of the M0 castrate-resistant prostate cancer case, where the PSA is going up, but conventional imaging hasn't identified sites of disease. Interestingly, when they started looking at the use of PSMA PET in this population of men, and this was a sort of retrospective study of 200 men who would otherwise fit the criteria for starting an ARAT on or for M0 castrate-resistant prostate cancer, they found that that PSMA PET identified sites in disease in almost all men, 196 out of 200, and that among about half of those men, there was sort of isolated local regional disease that was amenable to some sort of salvage therapy. So this idea of M0 CRPC may actually be going away in the setting of PSMA PET CT availability, and our management of these men may be shifting more towards more lesion-directed therapy early on to try to delay next line systemic therapies, because all of those therapies have additional toxicities, and if you can get more mileage out of your existing androgen deprivation therapy with simple drugs like LHRH agonists and such, then you may be sparing men toxicity, or you are at the very least sparing them other lines of therapy that can be deployed further down the road. And again, this is just showing that the treatment utilized in these men with local regional recurrence detected on PSMA PET skewed towards more lesion-directed therapy with radiation or stereotactic radiotherapy, and then those men who had more advanced disease detected on PSMA PET, as you'd expect, skewed more towards systemic therapies like androgen receptor pathway inhibitors, chemotherapy, etc. So what we've seen, just very broadly, is a real divergence of management options for men when we're using them, when we're using PSMA PET imaging to help direct their therapy. So for example, on the left panel here, without PSMA PET guidance, you have relatively few treatment options based on clinical parameters or clinical scenarios. And then with PET-CT, if you better understand the extent of the cancer, you now have a much more diverse set of treatment options that range from different systemic therapies to different combinations of surgery and radiation for lesion-directed therapies with or without systemic therapies. So you have this wide divergence of management options. The challenge is understanding whether this divergence in treatment really improves outcomes. And so this is a focus of ongoing research like the Patron study. So with this in mind, I just will review a few important trials, largely addressing now the oligometastatic setting, so situation where prostate cancer has recurred or has presented outside of the pelvis, so outside of the prostate in the regional pelvic lymph nodes. And so this study is called the STORM trial, and really tries to address the question of, if you've had prior therapy with radiation or prostatectomy, rising PSA, and now you've used PET to identify recurrence, and this recurrence is localized to regional pelvic lymph nodes, what should you do? So one approach is to say, just use lesion-directed therapy, lesion-directed surgery or radiation to the involved PET nodes, or involved PET-identified lymph nodes, or alternatively, appreciate that PET might be underestimating the extent of nodal recurrence, that there might be micrometastatic disease in some of the other regional lymph nodes, and in that case you should take a more comprehensive approach to do elective nodal irradiation while giving more intensive treatment to the PET-identified lymph nodes. So this study actually randomized men between those two approaches. So men with regional nodal recurrence after primary treatment were randomized to elective nodal radiation, where all the regional lymph node chains were electively treated to a moderate dose, and then involved lymph nodes were boosted to a higher dose, versus radiation just delivered to the PET-identified nodes. And what they found was that there at 3 years, there was a significant improvement in biochemical control, so PSA coming down and staying down, with the more comprehensive radiation. So 2/3 of men versus 1/2 of men with disease control at 3 years if the elective nodes are treated. So this type of data is, or these type of data are important for helping us to understand how best to utilize the PET information in terms of treatment intensification. Another set of influential studies were the STOMP and ORIOL trial. These were important because the comparator arm here was standard of care, which is mainly observation, versus metastasis-directed therapy. In the STOMP trial on the left, these men were primarily imaged with choline PET. On the ORIOL trial on the right, these men were primarily imaged with PSMA PET. And what both studies showed was that compared to standard of care, which would be care without metastasis-directed therapy, that there was a higher androgen deprivation-free survival with treatment of the PET-detected lesions compared to without treatment. So basically, keeping men off hormone therapy longer. And in the ORIOL trial, an interesting finding of that trial was that this study was started in the early days of PSMA PET. So men on the ORIOL trial were actually randomized according to detection of oligometastatic disease on conventional imaging. They had PSMA PET, but that was not part of the treatment decision making. But after the fact, they went back and looked among men who were on the lesion-directed therapy, the SABR arm, the SABR arm. Those men who had all lesions treated that were also detected on PSMA PET did much better than men who had only the lesions detected on conventional imaging treated, but there were some PSMA PET detected lesions that were missed. So again, this subset of patients on this study is some additional evidence that targeting therapy based on the PSMA PET improves outcomes of these men. Both of the STOMP and ORIO are relatively small trials. There's a next generation of trials which is being completed, which are large phase 3 trials. So one example being the Canadian Cancer Trials Group PR20 trial, also called Platon, which is randomizing men with hormone-sensitive oligometastatic prostate cancer, could be detected with PET or conventional imaging, and then randomized to systemic therapy with ADT or systemic therapy plus lesion-directed therapy with typically stereotactic radiotherapy. And then this trial is enrolling over 400 men and will follow men for freedom from failure and also overall survival. In the again, in this setting of recurrent oligometastatic disease, we can also see other types of comparisons that have been done. For example, in the hormone-sensitive space, looking at using combined SBRT and hormonal therapy versus hormonal therapy alone, or SBRT alone versus SBRT plus short course hormonal therapy. And we see that in the top two survival curves, that the combined therapy using short course androgen deprivation therapy with lesion-directed therapy improves progression-free survival compared to either hormone therapy alone or SBRT alone. And looking at the castrate-resistant setting, so that would be in the lower two panels here, the ARTO and PCS9 studies demonstrated that adding in SBRT to second-line hormonal therapy improved outcomes compared to second-line hormone therapy alone. So here is another case of a man presenting with synchronous oligometastatic disease. So in this case, high-risk prostate cancer, had PSMA PET staging, demonstrating a locally advanced prostate cancer, T3 disease, with involvement of the seminal vesicle in the middle panel on the left, involvement of regional pelvic lymph nodes, as highlighted in the upper panel on the left, and a single metastasis to the C2 vertebral body. And so in this case, we treated this man similar to a Patron type paradigm, but now with an oligometastatic focus of prostate cancer in the bone. So receiving local regional radiation to the prostate and involved lymph nodes, and then stereotactic radiotherapy to the C2 metastasis, and then combined with androgen deprivation therapy, but also systemic therapy intensification too, recognizing this man now has metastatic disease, so addition of an androgen receptor pathway inhibitor. And another case, again presenting with relapse after prior prostatectomy, salvage bed radiotherapy, another case of a man presenting with failure after prior prostatectomy, relatively low PSA at 0.6. Before PET, our plan of management was to treat the prostate bed and consider regional radiation to the pelvic lymph nodes and ADT. And at the time of PSMA PET, we now see that there was local failure in the prostate bed, but also 5 bone metastasis. So now we could understand that this man actually has oligometastatic hormone-sensitive disease, and so we chose to combine androgen deprivation therapy with an ARPI and stereotactic radiotherapy to all the PET-identified lesions, to the 5 bone metastasis and the prostate bed. Image here illustrating uptake within transverse process of one of the thoracic vertebrae. And then another case of a man relapsing with castrate-sensitive prostate cancer following a prior radical prostatectomy. PSA, again, relatively low at 0.29. Without PSMA PET information, our default may have been to irradiate the prostate bed. In this case, we identified a solitary focus of uptake within the sternum, and after discussing all of the options with this individual, chose to proceed with radiation alone, stereotactic radiotherapy to the PET-identified lesion. He was reluctant to undergo ADT, so we've used SRT alone, and his PSAs to date has been responding nicely. But again, without the PSMA PET information, we would not have treated this focus of cancer. We may have put him through an unnecessary course of pelvic radiotherapy, which would have been inconvenient and exposed him to toxicity without treating a known site of disease. So finally, if we look at the far end of the spectrum, where men are relapsing with castrate-resistant prostate cancer, and where does molecular imaging and theranostics fit into that setting? So here's a case of a man who has a fairly long disease trajectory, being diagnosed in 2012 and having radical prostatectomy, subsequent salvage pelvic radiotherapy, and then later lines of systemic therapy, including androgen deprivation therapy, androgen receptor pathway inhibitor with abiraterone, chemotherapy, and then a bone-targeting radionuclide, radium-223, but still having progression, and progression as evidenced by this PSMA PET scan on the left, where you can see on the maximum intensity projection many sites of increased uptake, and on the fused image, again, seeing many sites of uptake localizing primarily to bone. So the idea behind theragnostics is that you take advantage of the fact that you have chemical entities like small molecules that will target a protein on the surface of a prostate cancer cell, like PSMA, and then through medicinal chemistry you can link that molecule to a positron emitting radionuclide like gallium or fluorine to image the cancer. But it is also possible through medicinal chemistry to link that molecule to a different radionuclide, such as lutetium or actinium or terbium, iodine, which will actually deliver a therapeutic radiation to that prostate cancer cell, typically either an alpha particle in the instance of actinium, or an electron, a beta particle in the instance of lutetium or terbium. And this theragnostic pair, a diagnostic version of the molecule to image that the target is present and understand the extent of the disease, and then a therapy analog which will then target and deliver cytotoxic radiation to those cells. This theragnostics paradigm has definitely come into play as a treatment option in men with more advanced prostate cancer. So the pivotal trial here was something called the VISION study, where men with advanced castrate-resistant prostate cancer who had progressed after multiple lines of systemic therapy were randomized between a therapeutic form of PSA called lutetium PSMA 617, and those men were compared to men who were receiving standard of care treatment only, which could include things like palliative radiotherapy or changes in some of the hormonal drugs. And there was a significant improvement in survival with the use of lutetium in this population of men. This paradigm is being moved up early in the disease setting. So again, the CCTG has completed a randomized phase 2 trial looking at lutetium PSMA versus docetaxel as second-line treatment in men with hormone-resistant prostate cancer. And here's an example of a man we treated on this study. And again, we can see that this man had fairly projected disease course, initial radical prostatectomy, ADT for biochemical failure, enzalutamide, so an ARPI, androgen receptor pathway inhibitor, then progressed on that, and not yet exposed to chemotherapy, so randomized on the study between chemotherapy or lutetium as the next line of therapy. He was randomized to the lutetium PSMA, and one can see that in the middle panel, this is a SPECT scan done after administration of lutetium, showing that the lutetium is indeed concentrating in the sites of disease, identified on the PSMA PET scan at the far left panel. And then after 4 cycles, that uptake has virtually gone away, and then that's reflected in the PSA falling very nicely in the graph on the far right after his 6 cycles of lutetium PSMA. Now, as one would anticipate, this is not curative therapy, so with any of our systemic therapies, cancer will return. So in his case, about a year or so later, after his very deep nadir with his PSA started about a year after his lutetium therapy was started, he relapses and is now on docetaxel chemotherapy. But the PR21 trial, because it has this crossover, will help us to understand the sequencing of these therapies, because perhaps some of these therapies are more useful earlier in the course of disease versus later in the course of disease. A bit earlier in the again, looking at moving these treatments into earlier settings of disease, we have the OMPC trial and POPSTAR-2 trial, which is now looking at the castrate-sensitive setting and randomizing men with oligometastatic disease to either SBRT, so targeted radiation alone to the oligometastatic sites, to that alone versus radiotherapy with lutetium PSMA. The idea being that lutetium PSMA, because it's a systemic therapy, perhaps will ablate subclinical foci of cancer as well as acting with the SBRT with the known sites of disease to give a better outcome compared to SBRT alone, while avoiding the need for androgen deprivation therapy or hormonal-based systemic therapies, which carry a lot of side effects that men do not like. And we discussed that there are large randomized studies that are being deployed, and in the UK, the STAMPEDE-2 study is looking at castrate-sensitive metastatic prostate cancer. This study is breaking down men into SBRT eligible men, and then randomizing those men between standard of care treatment or standard of care plus SBRT. So this will give us a very large population for us to understand the efficacy of SBRT delivered to men with oligometastatic disease detected on molecular imaging with PSMA PET. And those men with more extensive disease are randomized between standard of care, which would be hormonal-based therapies, or standard of care plus lutetium and PSMA. So again, we will have a large population of men who are detected at an earlier state of disease to understand how these two PSMA PET informed therapies, SABR or lutetium and PSMA, how that impacts on their outcomes. And this study is enrolling several thousand men across the UK. And again, other studies which are in the process of reporting out or have been reported out, looking at this combination of lutetium and PSMA and standard of care and sequencing of these of this therapy at different stages of the disease. So, in conclusion, when we think about PSMA imaging and how it integrates with radiation therapy for prostate cancer, we see that it's improved the staging of high-risk disease. It's allowed us to better localize sites of recurrence after primary therapy, which will then enable metastasis-directed therapy, which can then provide men with more durable response and avoiding next-line systemic therapies, or avoid futile therapies where radiation might be considered to, say, the pelvis when cancer is actually outside the pelvis. We can adapt our radiation plans by either modifying volume or dose to address PSMA-detected disease. We can modify our choice of ADT or our intensification of ADT, and we can use PSMA PET imaging to select men for radioligand therapy, PSMA targeting radionuclides, which is showing a lot of promise across the spectrum of prostate cancer. So with that, I will conclude this introductory overview of PSMA PET imaging with radiation for prostate cancer. Thank you.